Chapter 30 Death, Dying, and Grieving. For our objectives will be to describe the evolution of life-saving measures and their impact on end-of-life issues. Also, discuss the role of palliative care and hospice in supporting patients and families who are facing chronic diseases and terminal illnesses. Also, identify the stages of the dying process as described by Kubler-Ross. Discuss the following topics regarding death, as well as artificial nutrition and hydration, euthanasia, and legally assisted suicide. Also, describe the components of advanced care planning for death. Advances in technology have blurred the line between life and death. Artificial nutrition and hydration, artificial breathing and blood filtering, and transplants have all gone a long way to greatly extend the span of many people's lives. Also, that aging population have presented unprecedented strains on the healthcare system as people are living much longer than they used to. There are many models for end-of-life care, everything from hospice, which is that standard for care for patients facing death. It begins after treatment has stopped and begins when it is clear survival is not possible. Also, should focus on patient care and symptom reduction. In the case of palliative care, would be to promote comfort and can begin at time of diagnosis, as well as focusing on the care for people living with serious illness. The key components of both models are honoring the patient and family experiences, as well as respecting autonomy and informed choice, allowing direction of care by the patient and family, and honoring the dignity of the patient and family. Mr. Dietrich has found out he has terminal brain cancer. At first, he and his wife just can't believe it's true. They leave the doctor's office silent and stunned, holding hands. They drive home in silence, but stop to get their mail as usual, pick up some fast food, and as they always do on a Wednesday. At home that night, he pops popcorn while she sets up the movie they've chosen. She looks at him and smiles. "Look at your appetite," she says. "It's wonderful. It's like you don't have brain cancer." "I think you're right," he smiles and squeezes her hand. For the Kubler-Ross's 5 stages would include denial and isolation, anger, bargaining, depression, and acceptance. For facilitating death, the first concept would be artificial nutrition and hydration. The supplementation of food and water is not a comfort measure, and is therefore not a component of basic care for the actively dying. It does not generally benefit people who are actively dying. In fact, providing artificial hydration by such means as intravenous fluids can increase edema, pulmonary congestion, ascites, nausea, and vomiting. Generally, the unwillingness or inability to eat and drink is caused by the impending death of the patient. In the case of legally assisted death or physician-assisted suicide, those of you who are old enough to remember Dr. Kevorkian from the 90s, he was a guy who was, in a lot of ways, unfairly demonized by the media. He was a physician who went a long way in advocating the concept of physician-assisted suicide, physician-assisted death. He actually went to jail for a long time standing on those principles, and now physician-assisted suicide is legal in a lot of states here within the United States. And in a large part for that martyr stand Dr. Kevorkian took. He went to prison for a long time for it. There's a great movie on HBO if you're interested. It's called You Don't Know Jack. It stars Al Pacino and is a fantastic movie to really give you that other side of Dr. Kevorkian's story. Because that legally assisted death, it really does have a lot of ethical principles such as individual liberty, autonomy, the quality of care, along with non-malfeasance and beneficence. Advanced directives. These are a statement of how you want medical decisions to be made if you cannot make them yourselves. They could take many different forms, such as a durable power of attorney for healthcare, or a living will. Also, provider orders for life-sustaining treatments. These are based on the patient's preferred code status in the case of a cardiopulmonary arrest. Since the 1960s, people have increasingly sought to participate in decisions about healthcare. In 1990, Congress passed the Patient Self-Determination Act. This required that healthcare facilities provide clearly written information for every patient, including their legal rights to make healthcare decisions, especially the right to accept or refuse treatment. The PSDA also established the right of a person to provide directions or advance directives for clinicians to follow in the event of a serious illness. For our case study, Mr. and Mrs. Dietrich meeting with the hospice nurse after 3 weeks of adjustment. "We'd like to help with advanced care planning," Mr. Dietrich says. His wife nods and holds his hand, trying not to cry. We don't want him to suffer. That's my main concern. If he can't survive this, I just don't want him in pain or throwing up a lot, things like that. She starts to cry and he gives her a shoulder to squeeze. For our first audience response question, which Kubler-Ross stage of response is Mr. Dietrich currently experiencing? That be A, denial, B, bargaining, C, depression, or D, acceptance? And that answer is D, acceptance. This is characterized by a calmer, if somewhat withdrawn response. Mr. Dietrich says, I want to get in writing from my doctor that I won't get any mechanical ventilation or cardiopulmonary resuscitation. None of that nonsense. Which advanced care plan is he expressing the most interest in? That be A, durable power of attorney, B, advanced directive, C, living will, or D, that provider physician orders for life-sustaining treatment? And that answer here is going to be D. And these are the orders the physician or advanced practice registered nurse writes based on the patient's preferred code status in the case of cardiopulmonary arrest in which heartbeat or respirations have stopped. Our objectives will be to distinguish nursing care at the end of life, including communication, presence, and symptom management. Also, discuss the process of death and associated care for the patient and the family. For communication, we want to establish a therapeutic relationship before asking the patients or family to make difficult decisions at the end of life. Think about the art of presence, symptom management, anticipatory grief, and palliative care for patients with dementia. Palliative care for patients with dementia involves difficult behaviors in dementia patients, such as irritability or refusal to cooperate with care, and are often forms of communication indicating discomfort in body, mind, or spirit. Anticipating a patient's needs can help prevent or reduce behaviors arising from an inability to communicate needs. Ask open-ended questions. Would you tell me what this is like for you? How do you see your condition right now? Where do you see things going? Are you worried about anything? And what are you hoping for? For anticipatory grief, that would involve the future loss as mourned in advance, adjusting life to accommodate the time that is left, foreseeing how the future will be altered by the loss, and anger is a common component. You want to encourage meaningful connections with their loved ones. Try to identify patient goals for care. Educate the family to minimize aggression during care. Eliminate medications that may detract from safety or their quality of life, and proactively manage pain and depression. Challenging behaviors may indicate discomfort in mind, body, or spirit. Proactively manage that pain and depression. For developmental tasks of dying would involve the completion of worldly affairs, the completion of community relationships, making meaning of one's life, experiencing love of self and others, the completion of close relationships and goodbyes, the acceptance of and finality of life, the sense of a new personhood beyond loss, sense of meaning of life in general, and surrendering to the transcendent or letting go. The dying process may involve a growing weakness, loss of appetite, increasing drowsiness, and a change in mentation, which would involve a shortening attention span, as well as difficulty processing information. It may also involve circulatory changes, such as an increased heart rate or decreased blood pressure, a mottling of the skin, including a grayish-blue splotches on the knees, ankles, and feet, a decrease in urine production, breathing changes such as Cheyne-Stokes respirations, and possible agitation and delirium. At time of death, the family should call their hospice provider. A registered nurse is sent to the home to guide the family members. Identity of the patient should be confirmed, pronouncing a time of death, post-mortem care, calling medical examiner in some cases, and contacting the funeral home. Sometimes family members are confused by the fact that the official time of death is the pronouncement time, rather than the time that the patient stopped breathing. It might be important to clarify for family members that this is the time that is used for the death certificate. Families will remember the actions of the nurse, so take care to communicate deep respect for both the dead and the bereaved. The nurse should also offer to contact a social worker or chaplain if desired. Family members should be invited to participate in this care if they desire. Care may vary according to culture, but may include bathing, combing of the hair, and dressing in a special outfit. For our objectives, explain the distinction between grief, bereavement, and mourning. Differentiate grieving, persistent complex bereavement disorder, and disenfranchised grief. And describe nursing care for individuals who are grieving and are experiencing complicated grieving. For grieving, grief is a reaction to a loss, while bereavement is the period of grieving after a death. And mourning refers to things people do to cope with grief. Grieving theories would involve Freud's concept of grief work. Kubler-Ross's emotional phases of dying have been identified with the stages of grieving. Bowlby's phases from shock to reorganization and recovery. Worden's four tasks of accepting, grieving, adjusting, and moving on. And Strobe's dual process model of coping and bereavement. When viewing the grieving process as linear, from denial to eventual acceptance, it's attractive. Grieving is just not that neat. In reality, these stages overlap and may be non-sequential. For Strobe, he suggests a dual process model of coping and bereavement. It incorporates the stage phase models of loss-oriented processing with the restoration of a new lifestyle. For grief and technology, it can be an outlet for expressing thoughts and feelings, sources of positive support feedback, and potential for loved ones to continue a bond with the deceased, such as sharing memories, expressing sorrow, and gaining social support. It can also help to make sense of death and helps maintain the legacy of the deceased. In one study, Facebook profiles of deceased individuals were reviewed for the posts made by loved ones. Results indicate a potential for loved ones to continue a bond with the deceased by sharing memories, expressing sorrow, and gaining social support. In grief versus major depressive disorder, grief would be feelings of emptiness and loss. Intensity, which are intense sadness and anger that occurs in waves and gradually subsides. And self-esteem, such as intact reorganization of tasks that may impact a sense of self, as well as thoughts of death that may focus on someday reuniting with the deceased. In major depressive disorder, these would be depressed mood and anhedonia. Intensity would be the depressed mood that is constant, and self-esteem, which are feelings of worthlessness and self-loathing. An individual who is grieving is clinically different from a person who has major depressive disorder. The previous edition of the American Psychiatric Association's DSM-4 discouraged clinicians from diagnosing an individual with major depressive disorder within 2 months of the loss of a loved one. This clinical guideline was referred to as the bereavement exclusion. For the types of grieving and associated nursing care, there could be acute grieving, which is the painful experience after a loss, as well as the nursing care such as listening, providing eye contact and suitable touch, and holding a posture of attentiveness, as well as supporting positive expectations for the future and re-engaging in activities and interests. With persistent complex bereavement disorder, this will be prolonged grieving and reactive distress that can lead to the impairment of relationships, occupational performance, and impacts day-to-day functioning. Nursing care would begin with a nursing diagnosis for risk for dysfunctional grieving, respond as for grieving, but protect from self-harm as well, and assist as needed with everyday functioning. For disenfranchised grief, this would be grief experience that's not congruent with a socially recognized relationship. Nursing care would involve combining support and guidance with individual psychotherapy, and consider an anonymous virtual support group. For grief caused by a public tragedy, this is loss felt broadly across the community or the general public, threatening our sense of security and altering our worldview. The pain is exacerbated by 24-hour media coverage. Think of things like 9/11 or the current hurricane in North Carolina. For self-care, think of things like countertransference, talk to a trusted colleague, protect your private life, admit to your limitations, and practice humility as well as doing your own mourning. And finally, for our last audience response question, after Mr. Dietrich dies, his hospice nurse finds that she feels devastated by the loss. Which type of loss does this most accurately describe? That'd be A, anticipatory grief, B, dysfunctional grief, C, disenfranchised grief, or D, persistent complex grief. That answer here is going to be C, disenfranchised grief. This is a grief experience that's not congruent with a socially recognized and sanctioned relationship, such as a loss of a lover, a pet, a caregiver, or an abortion, or the loss of a patient for a healthcare worker. But anyway, that's the last slide we've got in this chapter. I'll see you in the next slides.